Oi, pessoal. Terceiro dia do congresso do ISTH. Eu estou aqui para mais uma série de entrevistas, dessa vez com a presença honrosa aqui do professor Alok A, que desenvolveu o Scott Khorana, que todos nós conhecemos para a prevenção de tromboembolismo, e ele vai falar um pouco sobre as impressões dele e os trabalhos que ele está apresentando aqui. So, Professor, thank you very much for your time. You have huge number of doctors in Brazil that really look up to you, to your work, for all the contributions that you have done to the medicine so far with the Khorana score. So thank you on behalf of the Brazilian doctors, the cardio-oncologist doctors, as I am, and thank you for having a time in your busy agenda here to talk with us. Thank you very much.
Thank you for the invitation. I'm happy to be here. So.
Thank you. So, Professor, in these 3 days of ISTH Congress, we have been a lot of posters and lectures about incorporating some tools, some biomarkers, and try to find a personalized approach for our patients. Regarding the cancer patients and regarding prophylaxis of VTE, what are your thoughts about that? Because we always lose practicity when we incorporate more specific tools. Uh-huh. So please, how you feel that this thing will go for the next future?
Yeah, that's a great question, and I think that's the challenge for the field. So we are getting better at risk predictions. You know, the Khorana score is now 15 years old. Much has changed in cancer medicine since then. But the basic clinical features underlying the score are still very valuable, and it continues to be validated. Even today, we heard a presentation from a very large VA registry validating it. Many people are trying to improve on the basic score or try new scores, and one way to improve is by adding more clinical features. Another way to improve is by focusing on specific cancers, so having a risk score for myeloma, having a risk score for pancreatic cancer, having a risk score for lung cancer, that type of approach. And a third approach, which we also heard today at this Congress, is using more individualization by either proteomics type approaches. My research group is working on microRNAs, so small RNAs, to sort of find predictors of VT in cancer. So in a way, we can refine risk prediction to make it much more successful for individual patients. But how do we implement that in the clinical setting when clinicians are so busy, patients have so much burden on them, from the treatment of the cancer, and we don't want to add, some very difficult tests that can be done. So I think that's a real conundrum right now for the field.
Yes, but I feel that we will find a way to manage that and to incorporate. It's not way back to this movement. And also talking about bleeding risk, and that's always a sweet spot that we have to manage the thrombotic risk and bleeding risk. Having now available, not yet in Brazil, but I know that in USA, in Europe, the andexanet to reverse the anti-10A agents. Do you feel that will be a game changer for treating our oncologic patients? You as an oncologist, do you think that they will be change something or have been changing?
Yeah, I think it's definitely good to have a reversal agent, but the risk of bleeding on the direct oral anticoagulants is not very high, thankfully. And so in terms of treatment, we now have several years worth of data using all the different direct oral agents. And in the newer clinical trials, major bleeding rates are actually quite low. So it's good to have a reversal agent, but overall major bleeding rates are low. So I would encourage, physicians to use these drugs because you don't need the monitoring. And you do get sort of nuisance bleeds, so in somebody with like bladder cancer, you might see hematuria. So you have to be mindful about that, educate the patient. But thankfully, major bleeding is not a high rate. The field is moving, again, and one big new change in the field is the addition of factor 11 inhibitors. They are being tested right now in the cancer population. There's a very large trial of treatment of cancer-associated VT, comparing with apixaban and also comparing with dalteparin. So hopefully those results will also help us find a unit agent that has a reduced risk of bleeding, which is what the promise of factor 11 is. So
yes, we are always improving, and I feel that maybe it will be another game changer in the world of anticoagulation. And I saw your poster yesterday, and about the use of DOAC in elderly patients. It was amazing. It's safe. Because we are treating patients now in the 90s because they are in a good performance, a low catastrophic score. So that works, and it was amazing.
Yeah, I think with proper selection and education of patients, I think we can really select the right patients. With the advent of these current agents, 95% of patients will not have a repeat blood clot, and 95% patients will not have a major bleed. So it's great for patients.
Great for patients and for us to practice.
Make the practice easier.
Yes, it's a busy schedule for everyone. So, Professor, thank you very much for your time. The Brazilian doctors are very happy to have you with us and share your thoughts. So we are very grateful for that. Thank you very much. And you are invited to come to Brazil to visit our country and to take part in our symposium.
Yeah, I would love to come one of these days. So thank you for the invitation.
Thank you very much, Professor. Thank you. Bye-bye.
Bye-bye.
Tchau, pessoal. Até breve.